Hello everyone, Mohammed Chokr here, CA2 resident, Beaumont Hospital. Today we'll be discussing a unique case of respiratory failure following cervical fusion. Present a case of a 66-year-old female with a history of COPD, obstructive sleep apnea, who underwent C1, C2 bilateral fusion and instrumentation for cervical stenosis. Upon arrival to PACU, the patient was hemodynamically stable, awake, alert, and oriented. She was extubated without difficulty. About 15 minutes later, the patient became somnolent and acutely desaturated. She was given Narcan, Sugamidex, and subsequently she was reintubated. ABG showed severe respiratory acidosis with a pH of 6.9 and PaCO2 of 140. After she was adequately ventilated, the neurological exam showed bilateral upper extremity weakness and decreased sensation. In this presentation, we'll discuss the differential for respiratory failure in the PACU. Objectives are to discuss the differential diagnosis of hypoxia in the PACU, discuss the approach of respiratory insufficiency and respiratory failure in the PACU, and discuss the respiratory considerations for discharge from the PACU. Looking at the table at the bottom left, hypoxia in the PACU can be divided into three categories. First of all, you can have upper airway obstruction. Things like pharyngeal muscle weakness, laryngeal spasm, airway edema, foreign body, obstructive sleep apnea, cervical hematoma. All these can cause hypoxia. Next, you can have lower airway complications like bronchospasm, pulmonary edema, aspiration, pneumothorax, PE, and all these things need to be on our differential. And then last, you can have central peripheral nervous system abnormalities like excessive opioids, residual neuromuscular blocking agents, cervical surgery complications, which is what happened in the case of our patient, maybe even a stroke. Looking at the table in the top middle, some risk factors for respiratory insufficiency and respiratory failure in the PACU. They can be patient-related. If the patient has COPD, asthma, obstructive sleep apnea, heart failure, tobacco use, higher ASA score, all this makes sense. The more respiratory comorbidities the patient has, the more likely they are to have respiratory insufficiency or failure in the PACU. It can be procedure-related. Where was the surgical site? Was it close to the diaphragm? Was it an ENT procedure that potentially caused some upper airway obstruction? Was it a neurological procedure that led to altered mental status and hypoventilation of the patient? All things that need to be considered. It can also be anesthetic related. General anesthetic is more likely to lead to respiratory failure compared to regional or sedation. Can be incomplete neuromuscular blockade reversal. Thankfully, this is less and less common now with Sugamidex being more readily available. Can be excessive opioid administration. Can be multiple attempts to establish an airway that led possibly to airway edema now when the patient can't oxygenate or ventilate properly. The approach to the hypoxic patient in the PACU, the most important thing first is to establish airway patency. If the airway is patent, you have time. If airway patency is severely compromised and you see things like intercostal retractions, stridor, silent lungs, the anesthesiologist needs to act quickly. We need to make the decision of whether or not we need to reintubate this patient and establish the airway rather quickly, and then we need to act accordingly. Next, if there is airway patency, we can auscultate the chest. Look for any pulmonary pathology like wheezing, rales, crackles. We can see things like bronchospasm, pulmonary edema, atelectasis, aspiration. As long as that airway is patent, you have time to do a good physical exam. You have time to reach a diagnosis. If the airway is not patent, then you have to act accordingly. So a physical exam is extremely important in the PACU, especially because anesthesiologists are usually called when things are starting to go south, and we have to go there, assess the patient rapidly. So we have to make sure we're considering all these things together. Finally, is the patient obtunded? Is the obtunded patient, did they get too much opioids? Is there too much anesthetic left on board? Did they have any neurological complications? So you really have to put the whole picture together. Some things we can do, get an ABG analysis. This will show for the presence and severity of any abnormal gas exchange. You can get a chest x-ray. It'll show either a pneumothorax, pulmonary edema, foreign body, atelectasis. All things that will help us with our differential. You want to ensure adequate reversal of neuromuscular blocking agents. Narcan if excessive opioids were given, steroids for airway edema. Then finally, supplemental oxygen, anything from nasal cannula to intubation. Once again, depending on our physical exam, depending on the patient condition, you have to put the whole picture together and act accordingly. Looking at the top right, there's an MRI post-op day 0 of our patient after she was reintubated in the PACU. Basically, this MRI shows the anterior migration of the hardware that was placed for the bilateral fusion, causing severe cord compression that led to her hypoxia and hypercapnia. That patient was taken to the ICU for the next couple days. After her corrective surgery, she slowly regained some function in her upper and lower extremities, and was eventually discharged to a rehab facility. And according to the notes, about 4 months after the incident, she's pretty close to her baseline regarding motor and sensory. Regarding her motor and sensory, there's a CT scan at the top right as well. That was done 4 months later. In conclusion, a patient's airway patency, respiratory rate, and oxygen saturation is immediately assessed upon arrival to PACU. Patients with a high risk of developing respiratory insufficiency due to history, procedure, and anesthetic risk factors need to be monitored closely. Symptoms of respiratory insufficiency or failure are easy to identify in an awake patient, but may be difficult in a sedated patient. Hypoxemia and hypercapnia will cause agitation, anxiety, and confusion. Only when severe enough will they lead to obtundation and hemodynamic collapse. And then patients should remain in the PACU when they're no longer at risk of respiratory depression. So need to maintain adequate oxygenation and saturation for 15 minutes after the last dose of narcotic and or after discontinuing supplemental oxygen. Thank you everyone for listening. Have a wonderful day.